So with that, our next speaker is going to be Tom Judge and David Burr from Lifelight of Maine, talking about Maine IFR program and a lot of the work that's going on in that space and some of the really amazing things that we're seeing in Maine with low-level altitude. Tom, you ready?
Yeah, absolutely. Thanks, Rex, and thanks everybody for having us. Try and do a brief on this new piece in Maine. Let me just start, and then Dave is gonna fill in on sort of the technical pieces of it. I'm a medical guy, not an aviation guy, but I'm a systems guy. So let me talk a little bit, just provide a little background on how we got to where we are. So lots of you don't really know us. We're here in Maine. Maine has the most challenging aviation weather outside of Alaska. So we've got extremes of temperature. We have about 3,000 miles of coastline, hundreds of islands, the Labrador Current, which produces fog, coastal mountains, huge woodlands, the most wooded state outside of Alaska, lots of lakes, lots of water. So it's a complex environment to operate, and we have a very dispersed population. So from our standpoint, this is, and then 50% of what we do is at night. So that to us said that we really need to think about this, from a systemic sort of way. Now, we're also a little bit organized a little bit differently than other people that are in the air medical space around the country. We're probably more organized, like you'd see programs in Australia, New Zealand, Canada, and Europe. So we're a nonprofit charity, and we have sort of lots of both, do a lot of both public and private kind of organization. And also at the outset, just, all our aviation partners over the years have been, key to this as well. Keystone Helicopters, Sikorsky, there was an operator for a while, ERA Helicopters, and currently 7-Bar Aviation that work with us on doing pieces. So for us, the idea of IFR is that IFR is strategic safety and a systems approach to safety, whereas night vision goggles, which we utilize and are incredibly important to us, we would define as tactical safety. So it's, both sides are important, but from a system standpoint, the strategic development is important. Next slide. So this is a slide we actually shared quite some years ago now, back when we were first putting, the infrastructure work group. We've been around since the IHST started in 2007. And this idea of an IFR, that you've got the human side of this, the capable pilots, you have to have the aircraft side of this, and in our case, we've worked closely with our OEM Leonardo since inception. That we in the beginning did this with in a VFR system with IFR helicopters and pilots, just because we didn't have the infrastructure. And we'll talk a little bit about infrastructure and how we got to where we are. So we started this all in 1998. We knew, at that point, Maine was the only state in the country without any kind of air medical system. There was really no infrastructure to support helicopters. There were no helipads. There was limited weather, but we were like, we need IFR operations. So with that, we created a private-public partnership that involved the legislature in Maine with successive publicly funded bond issues, the Maine Department of Transportation, the Maine Department of Public Safety, the FAA, the USDA Rural Development, and then we've done a lot of close work with NOAA as well in building this out. So next slide. So the first part of that triad is where are you going to take off and land from? And we needed to find a way for our small rural community hospitals, even our big hospitals didn't have helipads, but to put in a proper helipad that, to the best extent possible for rural communities, often, pretty poor Maine is also not a very wealthy state, and to get those fixed facilities so that there's a proper, origin and there's a proper destination for every flight segment. And while we do lots of work for scene calls and we do lots of work in the woods, to the extent we can, we try to have, whether it's, we talked about this yesterday, whether it's a pre-designated emergency landing zone, whether it's a helistop, however we want to define it, to the extent we can, we try to have everybody linked into these fixed points facilities where we know we can safely take off and land. And so in addition to the helipads, there is probably about 1,300 designated landing spots around the country, around the state, and we about 140 of those are in remote areas, and those are again all private sort of lands, but we work closely in everyone in the state, Homeland Security, the fire departments, everybody, rescue, the wardens, everyone has access into an online system of where is there a pre-designated place to land, especially at night. So while we do ad hoc work, scene work, we try to limit that to the extent possible. So obviously the hospitals are our biggest piece, so fixed facilities there. Next slide. The next piece that we had to build out with this, if you're going to have a real system for IFR, is we needed to add weather. So we had obviously some weather systems in place at airports, AWAS and ASOS systems, but we've layered about 18 additional systems around the state into whether it's a hospital, whether it's into a small airport, to build out a weather grid that the pilots can access and that NOAA uses, so that our NOAA partners access all our sites, where some of these aren't in, even in the HEMS product now. They all are in the NOAA weather recording pieces for stuff. The next piece slide. The next piece we then had to put in is to put in approach and departure procedures at any hospital that was beyond a mile or 2 miles from an instrument procedure at an airport. So obviously, and then to build in at both hospitals and rural airports, and to a certain extent, some pre-designated landing spots. So up, you can look at sort of up in the center there, Kakajo is kind of out in the middle of nowhere, and to put a instrument approach into a woodlands area, so that and then all along our coastal islands, school ball fields, sometimes little tiny gravel airstrips, to put these in to where we can pick up people. So we know that we can get in and get out safely in different kinds of weather conditions. So we built out about 39 of those, and those the FAA manages and maintains for us under a partnership. Next slide. So then the next piece became, how do we tie all those places together in a pre-designated route system? And when we started that, there was really no way to, there weren't really a lot of helicopter routes in the country. There's a handful of them. There wasn't really public criteria to design a helicopter route. The third-party designers, that Hughes and Hickok and they've developed workarounds, because there really isn't, there hasn't been to date, how you would define this, and that most of these end up being at altitudes to have ground clearance where we are then in icing in a significant period of the year. So the question becomes, how can we tie all these primary spaces together with kind of a networked road system in the air, and then how can we build feeders from all our little procedures into these systems so that pilots can enter and exit safely? And then as we go into the future, how do we do that in a much more precision way, as certainly, we're not going to have a lot of stuff in that big central area of Maine where there's nothing but lakes and trees. But in our more urban environments where there's going to be much more activity in the air as the VTOL enters, how do we do that in a precision way to make sure that we can do this safely and working with our partners in air traffic control? Next slide. So this is really the next stage of the project. We started this about a year ago, right at about the same time we were doing the summit a year ago. This was about $10 million in funding that our senators got into the FAA to really build this new PBN route. And over the years, Mike Hilbert and Nolan Crawford and Mike Webb have briefed these meetings on the National Strategic Plan for Airspace and this idea of performance-based navigation. This went into an RTCA about how do we do low-level routing and get that down at precision, that, eventually we'd like to get this down to RNP 0.01, 0.1. We're at 0.3 now, and that's this first project that we're doing and the FAA collectively doing to build this out. So next slide. So you can see where we've done in the first route, and Dave will get into the technical piece of this in a second. But the first route, you can see Bangor in the center there, one of our bases, and then Bar Harbor down at Acadia National Park on Mount Desert Island. It's the second or third most heavily visited national park in the country. So while there's a fairly serene year-round population, in the summertime, there's a fairly significant flow-through population. So our first route we needed to do in a single air traffic space, air traffic control space. That's all in the Bangor the air traffic system space, and we developed and flew this first test route, flight checked it in December 8th, but also requires new procedures at either end, and now we're on to the next. So Dave, if you could pick it up from here and talk about the technical parts of where we are, and then we can finish up.
So one of the challenges that has been mentioned is the way to connect the routes. Prior to the beginning of this project, there are a number of operators that use special instrument approach procedures in a particular area, and were able to connect those procedures by using long feeder fixes. A number of things occur when that happens. One of them is that you are not able to go from other than special instrument procedure to procedure, and need to have clearance to do both those procedures at the same time. And if you take off from one facility and need to travel 3 facilities away, unless you can get clearance through all of those particular fixes, then you are actually not able to fly a route. And then the other part of it is that the criteria for obstacle clearance for the feeder fixes is much, it requires more airspace than it does for a TK or ZK route. One of the things that we particularly wanted to do was to make sure that we avoided that. And we also started back in the advent of the IFR process by looking at how are we going to be able to make this usable and sustainable for the process. Next slide, please. So one of the things that we did was we had to do a chicken and egg analysis, really. We began to design the system conceptually, and it made sense to start with weather stations, as Tom said previously. We doubled the number of stations throughout the state, and that made it possible for us to make go and no-go decisions for the facilities, because one of the things we really could not do was afford to waste the patient's time. Once we had the weather systems in place, then we were able to transition to IFR aircraft. Next slide, please. The aircraft arrived after the program, and the program soon transitioned to IFR. And it immediately became apparent that we needed to have specials to the hospitals in the remote or hard to access areas for a variety of reasons. The lack of nearby available alternates being the biggest, and then also the transitions from that Part 97 approaches to VFR or special VFR with unpublished route segments was another. There's a problem with transitioning from different sets of rules and depending on what types of airspace you're in. So more or less immediately, we began a multi-year process of developing the approaches. And what this is a depiction of the initial process for looking at how are we going to get out to the islands. Now, this was done a little bit over 20 years ago. This is something that now is done in targets relatively quickly and easily. The islands were one of the first places we decided to go because of the variety of challenges for the entrance for people into the critical care system. Access to the system actually is really the biggest. As Tom said, we've got more than 30 approaches, and we have more in development because we are still trying to connect all the dots. Next slide, if you would, please, Rex. So in order to make this work, to be able to enter the IFR environment, this is the Eastern Maine Medical Center. There's a number of different ways that we can get off that pad. We can, and because of the proximity of Bangor Airport, and that is also in Class C airspace. We need to either be able to request special VFR clearance to skip over to the local airport and then depart from there, or we could provide our own obstruction clearance. If we requested it and up to the MBA, if you punch in earlier from the hospital, doing a departure that way, even though we can do a good study and we know it's a safe thing to do, it makes people nervous because there's actually no published procedure for it, or we need to develop an ODP. So as well as the islands and the remote areas, it made a lot of sense for us to put approaches into the base hospitals, because the other part of this is that we need to be able to, we've got long leg lengths, and when you have a long leg length and a limited fuel supply, the closer your alternate is to your final destination, the better off you are with respect to being actually able to complete the task as planned. The requirements for the specials, for those that are unfamiliar, the procedure must be listed in an H-122 op spec, and that op spec for a Part 135 operation needs to be issued. The pilot's got to be trained, and there's special a training syllabus that the operator needs to develop to train to these approaches, and there's equipment manipulation that needs to be done, because an ODP is not a I'm sorry, the word just flew right out of my head. The CDI function is manual. It cannot be programmed to occur automatically, like the sequencing for an instrument approach procedure when you transition from the IFR environment to the terminal environment. The equipment will automatically scale itself down from an en route phase to a terminal phase, but the ODPs are not programmed that way. The utilization of the specials was good, but we soon realized that one of the limits that we had, or we are kind of bound by MEAs and MRAs and icing conditions. It's particularly when we were traveling east and north of Bangor. And that really was the driving force behind developing structure. Next slide, please. So where do you go? From the usage numbers, we developed a rough point-to-point design that went from location to location. This represents the operations out of ME02 or Eastern Maine Medical Center, which is located in Bangor. Next slide, please. This one represents what happens in the western area with ME95 or Lewiston operating as the hub of operations. Next slide, please, Rex. So the typical ODP that enables a pilot to depart under 135-613 mins with a VFR segment of a mile or less. This is what we would use to connect to the IFR or the IFR structure. One of the things that we've come across with the advent of the low-level route is that the termination altitude at the spear fix is actually higher than the altitude that the route would be flown. So there's a lot of work that's already gone to producing the ODPs and arrival procedures that unfortunately is going to have to be redone to connect them at altitudes that are more conducive to the route itself. Next slide, Rex. So to make all this happen, a work group was put together within the FAA to come up with a repeatable design process, and we were lucky enough to be the test bed. The key to this is the repeatable design process. The concept that I've already had up, the rough points, will be put into the target software, which is what you're looking at here. This is a mock-up of the actual width from waypoint to waypoint of the route that shows the actual distance from center line for the actual route segment, which is in yellow, and also depicts then where the approach procedures are going to be. Those are in up in the upper left-hand corner, the solid red line that goes from waypoint 414 down to the hospital, that's ME02 in blue, and the new procedure that's depicted down on the bottom right-hand corner of the screen in the red and white hashed line. Due to the complexity of the project, it was decided, as Tom said earlier, it was decided to keep all of this within the one controlling agency. In this case, it was Bangor. The idea behind this is that when you are going to run out on a low-level route and you're operating between control centers, it is likely that you may not have communication or radio communication from the departure point to the arrival point. So a number of things still need to be worked out about how we're going to do that and how flight following is going to be conducted, and also whether when you depart, in our case, depart from Bangor and proceed out of the Bangor's area, will you have your arrival clearance prior to departing Bangor's airspace? So what this particular segment will do is this ZK will allow the operations out of Eastern Maine Medical Center down to Bar Harbor at altitudes that are lower that were not possible before. This route will actually be below the MVA, and the distinct advantage of this is that it keeps us lower and allows us to operate for a longer period of time throughout the year to avoid freezing conditions when they occur. Next slide, please. This is the typical arrival procedure. Now, this was developed, almost 20 years ago by a private contractor. For those that are unfamiliar, this is more or less what the special looks like. The goal for these is to make sure that when you have the missed approach point that you are within a mile of the heliport, because then that will enables you to take the greatest advantage of the rules that are defined in 135.613. So the existing procedures, the only problem that we have now is that they're going to need to be amended for the lower IFR altitudes, because as you can see from here, the Hatso intersection on the T is up at 3,000 feet. The proposed route is going to be down at 700. And that makes absolutely no sense for us to be able to fly a route lower and then have to climb to get onto an approach only to have to descend again. This huge amount of work, I mean, this is incredible for the folks that are doing this chart work for the FAA. They've been absolutely fabulous about amending the approaches, and they're doing it in stride. The key is we have great support from them, and anytime it gets a little burdensome, next slide please, Rex, all you have to do is remember why you're doing it. This was a pickup that was done a number of years ago. I'm embarrassed to say that I don't have that much hair anymore, but this is coming out of Bar Harbor. So the typical patient transport is done. To get out, the ODP is required, and this will, because of the ODP, and the way that the ODPs are going to be set up with the departure points within a mile of the landing zone, we will actually be able to depart with lower weather minimums, than we have been in the past, because we will be able to park the visual segment of this under the 613 rule, not the 135.609 rule, which requires higher altitudes for a ceiling and greater visibility. And my apologies for the clock. Next slide, please. The example of the previous ODP, again, this will have to be reworked because the termination is at 3,000 feet. So this just adds to the workflow, unfortunate that the FAA has to do. Next slide. The current special into Eastern Maine Medical Center, the altitudes again on the T are higher than the ZK. So what the folks have done is we will have this procedure in place until the route is published and the approach is amended. Next slide, please. Conceptually now, what do you do next? So, got to catch up here. This is a conceptual design to connect Eastern Maine Medical Center, which is up in the top right-hand corner, to Portland, which is one of the receiving facilities. It's a Class 1 trauma center. It's one of 3 in the state that's down in the bottom left-hand corner. When these routes are put into targets, there's multiple screens that can go through. This is actually the depiction that shows the waypoints that are in the area. The lady who is running this program for us is absolutely fabulous, Christine Bays. I don't know how we'd do this project without her. When she jumps between these screens, she's able to manipulate the route to make sure that we can actually get the lowest altitudes possible. Ultimately, all the the specials that we have, we need to be able to connect them to the ZK or the TK route, whichever we end up with when we continue on with the project. After reviewing the usage numbers, we've set up a priority list to aid in the route development. Part of the process connecting the fixes of the existing specials and those of the Part 97 procedures that make sense for us to be able to have access to. As stated previously, the challenge is that the routes are below the altitudes for existing initials, and discussions are ongoing about how to connect the ZK to those that are already within the airway system. Next slide, please, Rex. So we continue to work with the FAA to break down a plan so the routes can be prioritized and into the workflow. This is the depiction here is of a route that has existing fixes that are within the airway system, and once this is actually laid out, it goes into targets and then it's put into prioritization. Once it's in targets, it can be checked to make sure that this is the way that we can get up to northern Maine at the lowest possible altitude. One of the things that needs to be looked at, and the questions that come up that need to be answered are the criteria for obstruction clearance, radar coverage and communications, and also ADS-B coverage, because if we don't have radar coverage and we need to be able to be tracked by ATC. It's almost going back to non-radar environment coverage, but with the advent of ADS-B, our position will still be known. The work group will take the information and looks at all the individual pieces for potential issues and resolutions. The work group is, I'm embarrassed to say that I don't remember all the people that are involved, but we have ATC, charting, design, policy and procedure, environmental and legal, and there's many more. And everybody has been absolutely fabulous and put a lot of time and effort into the project. They're also being really careful in recording the process to make sure that this is repeatable elsewhere in the country. In the beginning, you know, when we started the discussions, there were a number of folks who were dealing with it that were a little reticent because this has not really been done before on this scale. The really cool thing to watch is the way the group has morphed into, well, I don't know how we can do that, to, well, we'll figure it out. We'll just make it work. And if we can't make it work, well, we're still going to make it work anyway. I mean, it's been a great group of people to work with. Next slide, please, Rex. So the challenges. Some guys are going to think I'm sniffing glue for this, but this is stuff we've got to look at. Alternates and helicopters are a big deal, especially because of the limited fuel capacity and the current requirements under Part 135 for alternate selection. I'm going to steal a phrase that Nolan Crawford uses quite a bit. Modern helicopters and airliners of today, the only difference between the two is that the helicopter can't fly as high, as far, and as fast, but it can do everything else. We're currently flying machines that will fly down to 50 feet on an ILS approach and drive right down the center line of the airport. And they don't go to the side of the runway, they go down the center line. When they do LPVs, they are right on the money, right down to the bottom of the approach. So the reliability of the systems has increased dramatically since the rules were written. So unfortunately, we need to have the rules catch up to what we need to do today. I know it's a long process, but it's something that we need to explore. The problem that we have with Part 97 procedures is that and transitions to hospitals, we have a number of hospitals up here that are literally right over the fence of the airport, and it's very hard to try and make everybody understand why you can't, even though you are at the missed approach point, you can see the hospital, why you cannot go over there. We currently don't really have rules or procedures that are established to allow us to do this. We have rules that specifically say that some of the stuff we can't do, or when we go in under the Part 97 approach, when we get down to the bottom, we have to make a determination of what the weather minimums are, and the weather minimums will be different for the arrival versus the departure because of the VFR portion of the approach. If I put on my King for a Day hat, what would be great is to be able to figure out a way that we can have operators trained to develop ways that they can transition from missed approach points to the hospitals and do it safely. The FAA at this point doesn't have the resources to be able to do that. The scope of the project is just too big, and the rules really aren't there to allow us to do it continuously to go in and out under the same set of minimums. And that would be a benefit. We're not talking about doing crazy things. We're talking about being able to go someplace that you can see from where you are. And obviously, if you can't see the hospital from the missed approach point, you couldn't go there anyway. Part 97 approaches and this route. So at this point, there is no way that we can go or intercept an approach at other than an initial approach fix or an intermediate approach fix. So when looking at the previous depictions, or if you look on any instrument approach chart, that you'll notice that the distance between, or the altitudes, between the initial approach fixes, the intermediate fix, and the final approach fixes are all different. If we have, at this point in time, if we have a low-level IFR route that can transition through an area at an altitude that is 1,000 feet below the T altitude, or the initial approach fix, it doesn't really make sense that there is not a way for us to transition from the route to the Part 97 approach without having to climb. This is a thing that I have no idea how we could solve this problem other than to take a look at it and either come up with a different set of rules or have operators be able to request deviations. Cliff has been a big help with trying to work with enhanced vision to be able to improve the ability for us for safe transitions, and also developing rules in order for us to be able to use those. The goal is to be able to get guys into the IFR structure. So to be able to do that, they need to be able to get in and get out relatively easily, obviously safely, but have it be consistent so that it doesn't make sense for them to just say, the heck with it, our 135, 613 mins, our 609 mins will allow us to run around here at 800 feet and 2 miles visibility. So this IFR stuff is just too complicated, so I'll just do that. That is what we want to avoid. Next slide, please, Rex. And with all things, there's a lot, we all have questions, we all have a good idea of what needs to happen, but as the slide states, knowing is not enough. We must apply. Willing it is not enough. We must do. And the do part so far has been the hardest. And that is all I have, Tom. If you have anything else to add, add by all means.
So thanks, Dave. Yeah, thanks, Dave. And we'll sort of get to some questions here in a second. So, one of the other challenges, as Dave noted, is that he wants to put more and more fuel in a helicopter, and I want to put more and more medical equipment in the helicopter. So there's a natural tension there over distance and the alternates. We've had some great support, and we didn't get into the enhanced vision. That's also a part of this project. But without putting you guys on the spot, Cliff Johnson, Mike Webb, Nolan Crawford, any additions you'd like to make? These guys from the FAA have been working with us for years. Nolan's flown every one of our procedures multiple times in flight checks in previous roles at the FAA. But Mike, Nolan, Cliff, anything to add?
I can just chime in real briefly, and then I'll let Mike and Nolan can say something as well. I really very supportive of the work that we're doing with Tom and Dave, and Josh up there at Maine. They're great to work with, and I'm really happy to see this project move forward. And it's been a really great effort from all the people on the FAA side that are all working together on this. You don't get that very many times with our agency. Trust me, I know from working as part of it and towards a common purpose. And I think we're going in the right direction on this. I'm going to brief today on a little bit of some of the ADS-B analysis that we've been doing. We want to start looking at some of the procedural things. How do we see like the navigation aspects and keeping the tracks together. And then we also want to look at the vision systems aspects as well. And I anticipate that we will try to get some systems in Life Flight of Maine's helicopters and do some work with that in the near future. And I'll talk more about that during my discussion in about an hour or so.
Tom, this is Nolan. I would say that this has been one of the biggest collaborative efforts I've seen through the FAA to create this repeatable process that can be utilized in other parts of the country. It is using RMP 0.3 technology. It is using the newer technology that the aircraft provides. It will come with some changes to training programs and things of that nature. But I have to say thanks to all of my brethren across the FAA and the different lines of business, and also for Life Flight of Maine for being part of this program to allow us to establish this repeatable process.
And I would like to speak up and say that when Dante presents his presentation on the helicopter modernization program, the procedures that you want to see are included in what we are doing and changing the criteria. So we have heard you, and we are actively putting that into the new criteria and Dante will talk about that. He's not going to get into the details about it, but you'll get to see whereas we are improving the criteria from the 42B, one of the things that we are doing on incorporating that into the other documents is adding newer capabilities so that you will be able to go on your route, hit the IAF, and it'll be seamless going from the IAF around to the final approach fix. And you won't have to climb and descend. You won't feel like you're in church on Ash Wednesday or something. So,
and if you remember the chart that Mike and I have presented over the last several years, starting on the left side of the spectrum, where we said this is where you're at VFR. Here's your perceived VFR. Your perceived visually is in the middle, and where do you want to be? Well, where you want to be is where we're heading with what Dante is going to present, and what some of the stuff is that Life Flight of Maine is working on now. This is some of that new stuff that we've been trying to say is coming. Well, it is slowly coming, and again, thanks to the whole team.
Thanks. So Rex, we're happy to answer questions. I think that one of the pieces for all of this that everybody is always interested in is, why would we do this from an ROI? And I think Dave mentioned it, in the beginning, but for us, our constant challenge is, can we make the system safer at every point? And what do we need to do to continue to build a safer system? And that's, and the second question we always is, what can we do to make this more reliable? So we think this will impact, that a fully developed IFR system can probably impact, in excess of 20% of our patients. This part we expect is going to be about 8%, and that, that in the state of Maine, and that's obviously why our delegation's involved, that equates to hundreds of patients a year who would otherwise not get served. And in a rural state, and this is not unique to Maine, but in a rural state, the medical helicopters and airplanes often have more technology and more clinical capability than our rural hospitals. And so if we're going to give people a fighting chance, depending on where they live, we need to build a system that's safe and reliable. And, and again, huge thanks on our end. There's about, 40, 50 people from the FAA working on this, and the whole idea is that this can be then spread across the country nationally. So we're happy to answer any questions, and certainly appreciate the opportunity to brief on where we are so far.
No, sounds great, Tom. Appreciate the overview there, and thanks for a great presentation to both you and Dave. I don't have any questions in the chat box. If anyone has a question specific, please feel free to come off mute and ask your question.
Rex Tomecki with Wilbur here.
Go ahead, Tom.
Quick, very, very interesting. See a lot of connectivity with things that we're working on, as I mentioned in the previous briefing. The question is in regards to maintaining that level of safety, Tom, that you guys are mentioning. Has there been any thought into how maintained or updated spatial information as it relates to terrain and obstacles that may appear that weren't in existence when the procedures or the routing were developed? Has there been any thoughts or concerns about things such as temporary cranes or other activity going on that may impact those routes, and how that information can be captured and conveyed and then updating to maintain that level of safety?
Yeah, that's a great question. So one of the other pieces that we did early on as part of our investment in this, and we've invested heavily in this as well, because this is obviously aircraft training, but we updated, worked with our colleagues in the FAA and completely updated our 5010 database so that every place that has a procedure, so Vinyl Haven Island, where the procedure is to a school ball field, is in the 5010 database. And what we found almost immediately was that the database works. So as an example, we had inputted a little hospital in Skowhegan, Maine. It turns out that about 7 or 8 miles away, there's a giant paper mill. The stack is about 450 feet. 6 times a day, they use a drone to film the yard. So what ends up happening, they manage all their wood piles by visual drone measurements. And so, but their UAV was up above 400 feet, and that immediately picked it up. And so they immediately called and said, wait, so we're seeing now that anytime, and we have a good relationship with all the hospitals, they notify us anytime there's construction. We have a system in New England where we get that out to every air medical program. We update those kind of the informal, there's, the formal NOTAMs and the informal NOTAMs we update sometimes 3 and 4 times a week. We found the wind power people whenever there's a new project coming, we've become the first people they call. So the pilots are able to update our maps and flight quarters, constantly with pieces. And then we've also added, we have an infrastructure technician who supports the, weather cameras, the AWAS stations, hospital helipads, so that we're constantly maintaining surveillance. And then obviously in part of the partnership with the FAA is that they're doing regular 540-day flight checks on all the procedures, and this will now be all the routes. So we expect this first route to get published in March, and then we're working on all these additional routes, and looking at the publication schedule for the FAA to sort of line up timing for the next rounds of work. But it's a great question, because it takes constant surveillance to not run into some other problem.
Any other questions for Tom or Dave or anybody else on the line? All really pretty cool. And like I said, this has been something that Life Flight of Maine has really kicked off. And yeah, huge kudos to them for really spearheading this and being on the cutting edge.
I would like to thank Tom and Dave for their inputs. This is what the FAA needs to hear, is from the users that actually fly this and use this every day, what do they need? So that as we are doing the criteria, we can build into it to solve real problems and not just do what we think is the right thing to do. We're not the ones flying it. You guys are out there on the pointy end of the spear. And so it's very good for us to hear from this, that what it is that you need, so that we can make sure that that's worked into the criteria or into upcoming changes. So thank you very much.
No, good point. Thank you, Mike. Tom, any closing remarks?
No, thanks again. I mean, obviously, we're continuing to work with Senator Collins to continue the funding stream that'll continue after the project in Maine is done, because we obviously want to, make certain that all of this work is repeatable and reproducible around the country as part of our commitment to safer skies.